The question about what the appropriate empiric therapy is has to do with the assessment of the doctor with each patient. And when you first see the patient, you don't know whether it's MRSA or MSSA, and you can use this, even erythromycin for the old strains of staph. So each area of the world has a different prevalence of MRSA, and as we just learned, in some places in Argentina, particularly in the northern part of the country, the rates can be 70 or 80%, which means that every time a doctor approaches a child with skin and skin structure infection, if you don't use a drug that's active against MRSA, you run a very high risk of failing in your treatment. We see very little of the old hospital-acquired MRSA that's resistant to very many drugs, so it's very tough to treat. However, the old MRSA is not nearly as virulent as the community strains of MRSA. So even though it's harder to treat, the disease, the infection smolders and doesn't cause a lot of destruction in tissue, in contrast to community strains which cause tremendous destruction. For skin infections that are drained, shorter treatments or perhaps even no treatment is quite reasonable. The new strains of MRSA are very good at causing an abscess, but if the abscess is very localized and you can drain the abscess, then there are very good retrospective data to suggest that in those cases you don't even need treatment.